Good morning, students. Welcome to the class on blood. Today's topic is coagulation disorders. So in that first topic is Hemophilia A, also called as classic hemophilia. Genetics. It is the most frequently encountered hereditary disorder of blood coagulation in clinical practice. It represents 80% of all the coagulation disorder cases seen in the world. It has an excellent inheritance and it occurs due to mutation in F8 gene. In this, males are affected and hemophilic patients' daughters will all be carriers. So, suppose a father has hemophilia, his daughters will be carriers, but all his sons will be normal. Okay, because it is the X chromosome disorder. A carrier female has a 50% chance of producing a hemophilic male or a female carrier. About 2/3 of all patients have family history of hemophilia in the world. Factor VIII is primarily synthesized by the liver. It has half-life of around 12 hours. In the plasma, it is carried on to a factor called as 1 Hillebrand factor. The incidence of hemophilia A is 1 in 10,000 males. Normal level of factor VIII in the blood is 0.50 to 1.50 international unit per ml. Classification of hemophilia. Number 1 is mild. In this, factor VIII is 5 to 30%, and bleeding occurs only after significant trauma or surgery. Means these patients are in the day-to-day life, they don't have any problem. Only when they went with the significant trauma, they have problem. Number 2 is moderate. In this, factor VIII is around 1 to 5%. These patients get spontaneous bleeding after minor surgery. Number 3 is severe. In this, factor VIII is less than 1%. Here, patient gets spontaneous bleeding in the joint and soft tissue, and this occurs several times in a month. So, any patient coming with history of bleeding in the joints suspect hemophilia. So, mild disease, in mild disease, patient gets infrequent bleeding secondary to trauma. In severe and moderate forms, it is characterized by bleeding episodes, the joints, soft tissues, and muscles after minor trauma or even spontaneously. Coming to clinical features. So there is a coagulation disorder. Naturally, the patient will have bleeding. So it is characterized by excessive bleeding in the tissues, commonly joints, muscles, and subcutaneous tissues. So when it is seen, so newborn child when it starts walking, so at the age of 6 months, when baby begins to crawl or sometimes fall, patient may get bleeding. The bleeding may range from mild to severe. So bleeding into the joints called as hemarthrosis. Recurrent bleeding into large joints of the body. Particularly when baby crawls and falls. Falls mainly on the knee joint. Second joint commonly affected is elbow. So knee and elbow joints are commonly affected, followed by ankle, wrist joint, and hips joints are affected. Big joints in the body are commonly affected. This bleeding can occur spontaneously or following the minor trauma. In the acute stage, the affected joint is swollen. Because of bleeding, joint will be swollen. There will be some changes of acute inflammation, like rubor, calor. So the joint will be swollen, hot, tender, and movements will be severely restricted because of the accumulation of blood in the joints. This blood gradually gets absorbed over a period of days. So, and joint will be near about normal. But if this process occurs repeatedly, then repeated hemarthrosis result in deformity. So articular cartilage and bones will be deformed. The patient will get deformity and crippling. And muscles around the joint, because of not properly used, says becomes disuse atrophy of muscles around the joint. So this is bleeding into muscles. Second is muscle loss. So muscles commonly involved are the calf muscles and psoas muscles. Psoas hematoma. So psoas muscle, which is seen in the abdomen, that may compress the femoral nerve, so resulting in the sensory disturbances over the thigh and around the surrounding muscles, that is the quadriceps. So these muscles will be weak. Patient will have few changes: sensory disturbances over the thigh and quadriceps weakness. So often the patient is left with some residual weakness in the leg. Second muscle involved is the calf. Calf hematoma can result in contraction and shortening of the Achilles tendon. So patient will have difficulty in the walking. So this is the second. So any patient coming with bleeding in joint and muscles, suspect hemophilia. So what are other areas where you get bleeding? So the other bleeding manifestations are easy bruising. Suddenly starts bruising of the skin, surface tissue without any reason. Bleeding from the wounds. Patient has got wound. So like bleeding from the sockets after dental extraction. Suppose the dentist has removed the teeth and patient is getting suddenly bleeding, is not able to stop. Think of hemophilia. Other manifestations are patient may get hematuria and ureteric colic due to passage of blood clots, leading into muscles of tongue. Other areas where you get bleeding is in the abdomen is retroperitoneal, mesenteric, and intra-abdominal bleeding. So whole part of the abdomen, anywhere you can get the bleeding. In CNS, subdural hematoma, and in the brain, intracerebral hemorrhage. So any person, young patient particularly, has sudden bleeding anywhere in the joint, commonly followed by rarely you get in the muscles of tongue or abdomen or brain. Think of hemophilia. So to diagnose. So factor 8 is deficient in hemophilia A. Platelet count is normal. So naturally, if platelet is normal, on that depends the bleeding time. That will be normal. So platelet count and bleeding time are both interrelated. And factor 8 is related to clotting time. So naturally, as factor 8 is deficient, clotting time will be prolonged. Also, activated partial thromboplastin time will be abnormal. But prothrombin time, which is the vitamin K dependent factor, which is depending on vitamin K factor like factor 5, 7, will be normal. So for diagnosis, we should do the factor 8, factor 8, clotting time, and activated partial thromboplastin time. So once you diagnose hemophilia, just find out the factor 8 level is mild. Patient comes in which classification? Mild, moderate, and severe. And according to that, you have to start the treatment. In mild, as patient doesn't have any manifestations normally, so you don't need any interventions. Moderate, patient gets bleeding on minor trauma. So it requires factor replacement or events like minor trauma and surgery. So before any procedure, give him factor 8, or you can give the other factors that we are going to discuss in the coming slides. That is severe, where you can use the factor concentrates, which are virus inactivated, plasma derived, and recombinant factor 8 concentrates. But are very rare to get, rare, so easily not available. What else we can use? We can use cryoprecipitate, fresh frozen plasma, or if it is not available, we can use the fresh whole blood. Anything derived from the blood, fresh whole blood, or you can use cryoprecipitate or fresh frozen plasma.
ಹೈವೇ ಅಟ್ಯಾಚ್ಮೆಂಟ್ ಒಳಿಕ್ ಹೋಗೋ ರೋಡಾಗ ಇರೋದು ಮೇನ್ ರೋಡಾಗ ಅಂದಿದ್ದು ನಾನು.
discuss करना there is a technical problem with the internet. Sorry for the interruption. We'll continue with our topic, that is hemophilia and treatment. The third part is a severe hemophilia, where factor 8 is less than 1% in the body. So factor 8 is to be replaced. If it is not available, any product derived from the blood or whole blood, fresh whole blood, or blood derived products like fresh frozen plasma, cryoprecipitate can be given to the person. Other treatment modalities in hemophilia, particularly severe hemophilia, is antifibrinolytic agents like tranexamic acid, epsilon amino caproic acid. It is useful in the management of bleeding in the gums. So you can apply locally and stop the bleeding. Or anywhere during oral surgery, if you get bleeding, so it acts and decreases the bleeding. So to control local hemostasis, this is useful. Bleeding from the GIT, also this is useful. So for any local application, epsilon amino caproic acid is useful. Third modality is desmopressin. It acts by increasing the release of stored factor 8 from endothelial cells. It is useful in the management of mild and moderate hemophilia, but it has no role in the management of severe hemophilia. Now coming to management of acute bleed. Suppose any person with hemophilia, maybe has a severe hemophilia, has got acute bleeding. So what we can do? Suppose he got fall, history of fall in the, followed by joint is affected. The first is the, you have to do the rest to the affected limb. Cold compression with ice packs. Use the drugs like paracetamol or tramadol to relieve the pain. And if there is any bleeding is there, you can give the red cell infusion, whole blood infusion, or if factor VIII is available, factor VIII can be given to the person. And as soon as acute inflammation subsides, is around 5 to 7 days after pain is settled, start the physiotherapy to avoid the joint and surrounding muscles disuse atrophy. This is an acute bleed. In chronic, because of repeated hemarthrosis, there will be chronic complications. Management of chronic musculoskeletal complications. Deforming arthropathy. So where you get the articular cartilage is damaged. So treatment is physiotherapy. Pseudotumor, accumulation of blood in the calf muscles or in the psoas muscles. That needs surgical excision. Prognosis. Suppose these patients receive prophylactic factor replacement, particularly severe hemophilia, they can lead a near normal life. But if they are not affording or they are not able to get the factors, in that case, when factor replacement is less, then the major long-term complications are progressive joint deformity and crippling of the joints. So how to do that? Carrier detection and prevention of the disease in the families. So you can do by genetic counseling. In that, when your pregnancy is at around 8 to 9 weeks, chorionic villi sampling is done. So who are the indicated persons? Pregnancy of daughters of men with hemophilia. So affected male, if he gets daughter and if the daughter gets married and they are pregnant, so these are the persons who are required to be subjected for this procedure. And wives of the mothers with an affected son. So any mothers who has affected son, and that son marries a person, and if that person gets a daughter, that wife gets pregnant, they are the person who are to be subjected for genetic counseling. There is a internet problem, so just bear with me for 2 minutes. Coming to Hemophilia B. Also called as Christmas disease. It is an X-linked then X-linked recessive disease. It is due to mutation in F9 gene. It is due to factor 9 deficiency and seen in 20% of all cases. Clinical features: hematomas seen in the muscles and hemarthrosis. Diagnosis is done by estimating the factor 9 levels, that is decreased in these persons. Treatment: can use fresh frozen plasma or factor 9 concentrate. Coming to third topic, that is 1. Willebrand's disease. In short, it is also called as VWF. It is the most common inherited bleeding disorder. It results from dysfunction of this factor VWF. It is characterized by autosomal mode of inheritance. The gene is located on chromosome number 12. It's a protein synthesized by endothelial cells or megakaryocytes. And it has two main functions. One, it acts as a carrier protein for factor 8. So factor 8 is carried by VWF. So if a deficiency is there of VWF, it causes secondary reduction of factor 8, leading to a coagulation defect. Second function is it plays an important role in platelet adhesions by forming bridges between platelets and subendothelial tissues. So platelets are bound to subendothelial tissue by VWF. So deficiency of VWF results in defect of platelet function. So factor 8 and platelet both are dependent on VWF, just like classification. There are three types. Type 1, where you get mild bleeding. Type 2, where you get moderate bleeding. Type 3, where you get severe bleeding. Coming to clinical picture. In mild and moderate disease, bleeding occurs after trauma or surgery only. So patient goes unrecognized. In severe forms, we get spontaneous bleeding from the nose, called as epistaxis, gum bleeding, or from GIT, gastrointestinal bleeding, lower GIT bleeding, bleeding through the rectum, or menorrhagia. But joint bleeding is uncommon. This is different from hemophilia. Where in hemophilia, joint was commonly involved. In BWF, mainly other than the joint, oral cavity, or GAT, or genitourinary system, where you get bleedings. Diagnosis is done by estimating the factor 8, which is reduced, and BWF, which is also decreased, and bleeding time is prolonged because bleeding time depends on platelet functions, and platelet functions again depend on VWF. So VWF is deficient, means platelet function is decreased, and so bleeding time is prolonged. Activated partial thermoplastin time is also prolonged. Coming to treatment part. So in mild bleeding, I don't have any problems. Patient doesn't have any problem. But you can use, if suppose patient gets problem, you can use desmopressin, also called as DDAVP. It is an analog of vasopressin and increases the plasma levels of VWF by releasing them from endothelial cells. In severe hemophilia, you can use intravenous. In severe bleeding due to VWF deficiency, you can use intravenous cryoprecipitate or VWF concentrates. For any oral surgical procedures, local hemostatics like ESCA can be used. The dose is 5 gram 4 times a day to be given for 7 days. Any patient has got menorrhagia, so you can use the hormonal suppression. So this is VWF, von Willebrand disease, where you get bleeding other than joint. Okay, oral bleeding, epistaxis, or gum bleeding, or gastrointestinal bleeding from rectum, or menorrhagia. Suspect VWF disease. Coming to last topic, disseminated intravascular coagulation. As the name suggests, it is a very big and it is a very problematic disorder where you get coagulation all over the vessels. That's why it's called as disseminated. Etiology. So commonly etiology is the obstetrics. So whenever any pregnant female gets some problem, so in that common problem is suppose fetus is suddenly stop moving. So that is the intrauterine fetal death. Or suppose there is septic abortion. Or suppose placenta has some problem, abruptio placentae. Or Fetus is surrounded by fluid, amniotic fluid. So that fluid leaks out into the system, giving rise to embolism. These are the three to four common obstetrics problems. Then any disseminated infection in the body, sepsis due to staphylococci, streptococci, to gram-positive organisms, and gram-negative bacilli infections due to Pseudomonas, Klebsiella, or any other than that falciparum malaria, where you get this DIC. Tissue injury, particularly in trauma, burns, fat embolism. The malignancy of prostate, hematological malignancy, particularly acute promyelocytic leukemia. Then mismatched blood transfusion. Person receives blood for anemia or during pregnancy. And suddenly, mismatch occurs and gives rise to disseminated intravascular coagulation. Any bite, particularly snake bite due to viper or scorpion, can present with DAC. Pathophysiology. It is a disorder where unrestricted activation of coagulation leads to formation of excessive amounts of thrombus, causing consumptive coagulopathy. That means all the coagulation factors are used, so that leads to decrease in the clotting. That leads to decrease in the clotting factors, particularly factor 5, 7, fibrinogen, and platelets. So diffuse intravascular clotting results in utilization of coagulation factors 5, 7, fibrinogen, and platelets, which in turn lead to bleeding. So, patient has got bleeding, particularly in the organs, suspect PAC. So, clinical features, skin and mucosal bleeding. Simultaneously starts from multiple sites. Start from oral, gum bleeding, nasal bleeding, epistaxis, gastrointestinal bleeding, bleeding per rectum, fresh blood, also called as hematochezia, bleeding from the urinary tracts. So urine becomes red color. So patients start simultaneously bleeding from the either upper orifices or lower orifices. Think of DIC, disseminated intravascular coagulation. So what are lab tests we can do? So in that, most common is the times. What are these times? Prothrombin time is prolonged. Activated partial thromboplastin time is prolonged. D-dimer is increased. Platelet count is reduced because of usage of platelets in the thrombus formation. Fibrinogen is reduced. Peripheral sphere shows fragmented red cells called as cystocytes. So, person has got bleeding, multiple sites. Think of DIC. Now coming to last slide. What is the treatment? The treatment first is the correction of precipitating cause. What caused the DIC? So first we thought, so that for that you should know the etiology. So etiology already we have discussed. Most common is the sepsis, the gram-positive sepsis or gram-negative sepsis, okay, or obstetrics. problem. Commonly, in that case, we need the termination of pregnancy. If fetus is dead, removal of dead fetus. If there is placenta is retained, remove the placenta from the uterus. Second treatment is to replace the depleted procoagulant factors. The first, that is the fresh frozen plasma. It normalizes their coagulation time, PT and APTT. Platelet concentrates to achieve a platelet count of around 50,000. So, coming to the end of this topic, today we will discuss 4 different parts. Hemophilia, where you get bleeding in the joints. Factor 8 or factor 9 is deficient. VWF disease, where you get joint is not affected. Bleeding can occur from the oral cavity or gum bleeding. Last we discussed DAC, where you get multiple time bleeding, particularly skin, either oral orifices or nasal or some lower GIT or urinary tract.
ಅದನ್ನ ಸ್ಟೂಡೆಂಟ್ಸ್ ಎಲ್ಲ ರೇಸ್ ಮಾಡಿದಾರೆ ಅಂತ ಹೇಳ್ತಿಲ್ಲ ಕ್ವಶನ್ಸ್ ರೇಸ್